Hello and welcome. My name is Danish Bahati, and it's my pleasure to talk to you in the KEMCAANA annual winter meeting. And my first topic that I'm discussing will be contemporary trends in medical education. And my main message to you, and my theme of the talk would be that the main goal now in medical education has become more of teaching how to problem solve in the context of medicine, and not really the content itself. The content is becoming less and less significant, especially with the advent of large language models. The information is literally at your fingertip now, and but problem solving is still mostly dependent on humans and not taken over by machines in near future. I have no disclosures related to this talk. So let me start with a basic question to you as we discuss medical education. What really is learning? And the simplest definition that I can find that is often used in machine learning is that learning is a series of sequentially changing generalizations. So imagine you try to teach someone, a patient with cough. The patient has cough with, the first patient they see has tuberculosis. Then anytime they see a cough patient, they're thinking tuberculosis. But you want to be able to have them more general thought that the cough can be caused by other things, and then you gradually show them other cases so that they can start thinking about what other factor besides the cough will help them determine that this is tuberculosis or not. So it's literally a series of sequentially changing and improving generalizations from the specific symptom that a patient or medical student is seeing. So how do the students learn, or how do we learn? And what we typically do is that we take known data and then we try to apply it to unknown data for decisions. So I mentioned this changing generalization. You take known data, okay, someone has cough, they have tuberculosis, then they say, well, not everyone. So someone who has cough and older age, or cough with weight loss, or cough with fever at nighttime, and you're taking information from previous patients that have been seen by you or by someone else, and they have taken some shortcuts to decisions, and they are teaching you those shortcuts or rules and then exceptions to try to make you problem solve a case. So let me give you an example of how we used to teach. So let's say you're trying to train a neurosurgeon or neurologist in this context of deep brain stimulation. We're putting wires into the deep part of the brain, let's say subthalamic nucleus. Now, this learning starts, of course, in medical school because the resident cannot learn until a student has been taught. So the learning often begins with the context of teaching them about subthalamic nucleus. So that was the tradition, right? So all these textbooks that we will read will have all these details about subthalamic nucleus, as you can see summarized on this page here, and all the anatomical detail. And then you will test it if they have absorbed this information by asking them a question. So question will look like something like this. There will be a clinical scenario given, and then after the clinical scenario, you'll ask them, okay, select all of the following is true. And you're trying to see how much of that information you gave them or you gave as a lecture or in a textbook was retained by them. But really, what you're actually trying to teach is the this visualization that when they come to a residency in neurosurgery or neurology, and you're trying to tell them about placement of these leads in the brain, then they can visualize the anatomy of subthalamic nucleus, right? And so it's not in itself is not important that how many millimeter STN is and how which direction it is aligned in, but it is in context of something that you're trying to do to the patient, and that's what you're trying to teach and test. And you can create a visual test, and a question can now look like this. You can ask that when you're placing in a clinical context leads for subthalamic nucleus stimulation, the surgeon makes a track a little too lateral and ends up crossing which of the following structures. So now you're not asking a question in terms of, okay, how many millimeter is this and how many millimeter is that. What you're asking is a more relevant practical question that as you are trying to place a lead as a resident, and what mistakes you can make if you put it too lateral, what would you cross, right? So this is an improvement, but it's not the final solution yet. And that's what I wanted to highlight. So what you're really trying to do is that when you see a patient who has deep brain stimulation surgery done and comes in with some problems, and you are trying
She's
to
had a regular release, a time release, and I gave her
animal
half
how can they problem solve that issue?
regular
So
release
the the
around
actual
9:30
context
or so.
is
Now, how are you
paramount,
feeling?
not really the information itself. So it doesn't matter if they
Okay.
know the subthalamic matrix anatomy in itself, if
The
they can
tremor
actually
looks a lot
solve the
better, that's
patient's
for
problem.
sure.
So patient comes in and he's
So with your
experiencing
hands, go
whenever
like
you
this real
increase the
fast.
stimulation, some tightness pulling on the face and shoulder. And the question is that,
And then
was
on
the
the other
lead
side, on your
placed too
left.
lateral or too medial or too anterior to posterior? So procedure itself is only relevant in the context of the clinical scenario, clinical problem that someone is trying to solve. So how do we teach problem solving in what are the contemporary trends in teaching those problem solving techniques? So the biggest challenge with the education is that, in that the student that the teachers need feedback of what student is absorbing. So when you teach something to a student, it doesn't automatically mean they got it, and it doesn't automatically mean they can actually now use that information to solve a problem. So why not then focus on giving them content and testing their problem solving, or helping them build the problem solving is more important, by constantly getting a feedback from them or testing them with real scenarios to see can they figure this out. But these are the 7 evidence-based principles of what they has called student-centered learning. But the idea of student-centered learning is that teaching students the problem solving or techniques that they would need to actually practice medicine, and not necessarily the content that is available in the books. So you're not creating encyclopedias, you're creating problem solvers, right? So you would see that in these 7 principles, there is not much comment on the content itself. The question is on, okay, what does students' prior knowledge or context is, or how is student organizing the information? What is a student's motivation? How they can reach mastery? Why is targeted feedback useful? What is the climate of learning, and how you learn to monitor their learning, and how do they learn to monitor their own learning? So all these principles are more about how to teach them the problem solving and not the content itself. So let me start by first talking about technology, integration into education. And again, all these technologies doing is helping you create those tools to teach problem solving. So what are those tools? You can use high fidelity mannequins to do various simulation exercises. For simulation based learning, you can use virtual reality and augmented reality to enhance their clinical skills in a simulation environment. And I'll show you some examples in the next few slides. And then you can use artificial intelligence based platforms that can help personalize the learning. Someone may be behind in one area than other. You can do adaptive testing, where as they get better in their information or problem solving, then you can adapt the test to become a little more harder so that they continue to be challenged. And then you can also do predictive analysis on where the students are and where would they end up, or who are the weak students in the class, so that everybody has the best chance of being a useful physician. And then, of course, remote learning and telemedicine training is becoming really popular, especially for if you don't have the expertise locally available in your own area, then you can get access to remote learning. So let's look at some examples. So simulation-based learning, I mentioned mannequins before. Many centers, including my center, University of Central Florida College of Medicine, have a clinical skills and simulation center. The center has multiple exam rooms. Now these are patients, or these are students who are in the preclinical area right now, and they have not really gone into clinics. And you're preparing them to get to clinics so that they can perform the best in clinics and also learn the best in clinics. So you're teaching them some basic skills that they would need even before they start the clinics, right through the preclinical years, which probably is a big change, definitely a big change from when I did my medical school in KE. And you're using all these mannequins to teach them some of those skills that they can hit the ground running, as they say, when they get to the clinical areas. You can find more details here. You can find a complete list of the mannequins and different things that we use. In UCF, you can also search UCF College of Medicine Clinical Skills and Simulation Center on Google, and you'll get to this page with all the details there. I mentioned I mentioned the augmented reality and virtual reality. So what virtual reality has offered you as a tool is to provide a 3D visualization of very complex content. I give neuroanatomy as an example because I'm a neurologist and it's one of the hardest content to learn. And you are really pulling the brain out of that 2D screen or the page of a book, and making it that 3D shape that will help them understand the whole anatomical localization, medial, lateral, and so on and so forth. Traditionally, we have done it through anatomy labs or autopsies or dissections, and that has helped a lot. But there's always limitation of how much you can learn in a dissection, how much you can manipulate a dissection, and how much skills you have to do that dissection appropriately that can be compensated by or augmented by the virtual reality. Augmented reality is taking the information of virtual reality and really putting it on a real world. So here is an example that you're taking a real 3D, a real MRI of a brain, and then you're augmenting the that MRI of the brain, a 2D MRI, by 3D anatomy that I previously showed, and projecting it in appropriately onto that scan. And these techniques are already available. They're great for learning, but also they're even very useful for surgical planning and so on and so forth. Another thing that you can do, I mentioned, is the teletraining or telemedicine. Robotics is coming very common and may eventually make it to the medical school. Right now, it's more of a residency thing. But one thing I wanted to show you here is that you can see the patient here on the table, and there are these robotic arms that are operating on the patient. These arms are being managed by the physician sitting in the kind of this cubicle here, and they're looking at very high definition information, augmented and enhanced rather than just their eyes through these cameras or video feed. But the point here is that they're only a few feet apart right now, but they don't have to be. This same exact robotic manipulation can be done from miles apart or even oceans apart with the fast internet with minimal lag, and they can perform all these surgeries. So separating these few feet is not the achievement, but what this now opens up is that the same surgeons can be sitting in a different country and can manipulate these robotic arms to do the surgery with local nursing help available or local junior surgeons available to help with the surgery. And all of this will get into training already in residency, but will probably get into training for students, because what if they are sitting on these tables and there is no patient there but a simulated patient that they're seeing through the camera, and all this feed can be generated for them without actually having a patient there, and AI is making decisions based on their steps on what next to show them or what mistakes they're making. So really can be extremely useful for learning. So I want to now switch over to this important concept of competency-based education. So all these tools that I have shown you and others that I was not able to show you are trying to give you this empowerment to do skill training that I mentioned earlier, problem-solving learning around, and this framework is called competency-based education. And you're creating competency by not only those tools, but also changing the way you teach. So, for example, more and more medical education is switching over to case-directed learning, where clinical scenarios are given to the students, even in preclinical years, to solve or discuss the preclinical information or basic sciences information around those clinical scenarios. And a lot of these discussions are now in small groups where they work together to problem solve and get to the answers or information assimilation. And the information actually is not being given to them. So there is no seminar style lecture going on anymore. Content is already pre-recorded and given to you, just like my lecture is pre-recorded and being given to you. And it could have been given to you before you showed up for the sessions today. And then all we could have done is to divide you into small groups to discuss how you would implement this training. So that's the problem solving part, right? And all this leads to is this very important concept called entrustable professional activities, or EPAs. What exactly this difficult word means? It means that when a student graduates medical school and starts their residency training, there are some professional activities that you want to be able to entrust to them, because the concept of residency is supervised practice, but you can't be with the resident every single minute, and definitely not with every single resident. There's a lot of time that the resident has to work on their own. And we actually in Pakistan give that freedom a lot more than many other countries, including US. But for that to happen, and that to happen in a good way, you want you want to know that there are some professional activities that you can entrust to them, and the medical school had made sure that they were ready for those entrustable professional activities. Now let me break it down a little bit more for you. So, the competency based medical education basically says that it is more important to know what outcomes you are trying to train a medical student for and not the content. So, what is it that you want the student be able to do in the medical school, and then what is it that they need to learn to be able to do or be trusted with those activities. So what are the competencies that you want your medical graduate to have when they start the residency? And these entrustable professional activities basically operationalize those competencies. So if you define a competency and the question is, okay, what does that competency lead to? You can say they are competent to take care of patient, but what does that mean? What is it that they are able to conduct with the patient? That means that they're competent to take care of the patient to a basic level, and that those professional activities that they can do with the patient will be the entrustable professional activities, which is guided by or defined by the competency that the student has. The AAMC, American Academy of Medical Colleges, they published in May 2014 a guideline of 13 core entrustable professional activities they thought the student should be able to be entrusted with when they graduate the medical school and they start their residency on day one. And then they did a pilot with it with 10 schools from 2014 to 2021 and published the report in September 22. And that what the transition looked like going towards these EPA goals, or competency-based education, or problem solving, what I'm calling, and not the contents-based education. Let me expand this a little bit more to you. So the competency is defined by a milestone. Milestone is that, okay, how far along your medical skills have you reached? So for example, at the end of the medical school, a student should be able to, or a doctor should be able to perform a focused history and physical examination, abstract the current findings in a patient with multiple chronic medical problems, and when appropriate, compare with the prior medical record and identify significant differences between the current presentation and past presentation. So basically, you're saying that if a resident day one sees a patient who comes in who has prior medical problems, is coming for a follow-up, then they should be able to perform a relevant history and examination, not all the history and all the examination, relevant to their visit, extract the information, sort out what's going on, what's different now than before. Let's say they're having diabetic retinopathy and they were previously diabetic, or they're hypertensive and they're having uncontrolled hypertension and that's leading to some problem. I'm just expanding on of that. And how do you expand to that milestone? How do you think that the student has reached this competency level, this milestone of that competency? And you break it down by defining, okay, what can you entrust the student to be able to do? So for example, you want to be able to, the student or resident to be able to gather a history and perform a physical examination, prioritize a differential diagnosis, form relevant clinical questioning to retrieve evidence for patient care, figure out, okay, if he is now developing diabetic retinopathy, his A1C is this level, what should be my next step? And then recognize what is urgent, patient is having hypertensive urgency, emergency, needs to be sent to the ER, and what is emergent and what is just a chronic care that can be done. So all of these should be entrusted to a resident if they have reached this milestone. Now, to be able to know that you can trust them with this professional activity, that they are entrustable, you need to be able to observe a professional activity that validates that they have reached this EPA. And once they have hit all the EPAs, then you can say, okay, they have reached that competency or that milestone of the competency. So you should be able to observe them to take different components of history. For example, that they are asking about medications, that they are performing a basic cardiac examination, they are performing a basic eye examination, fundus examination, they are performing relevant social history. They're asking about drug of abuse, alcohol abuse, they're asking about their diet and so on and so forth, that will have an impact on medication adjustments and cardiac examination. Once you observe all of these, then you can say they have reached EPA, and then when they have reached the EPAs, then you can say they have reached a milestone. This is that complete shift in thinking of medical education that is taking over medical colleges and probably many other places, but I can tell you about UCF College of Medicine. We're completely going through a transition of our preclinical education and clinical education to go over this concept of milestones. And then the last few words that I would not be able to go into detail is that it's an important shift in medical education these days is trying to train in the context of where they will be working. So a medical resident will not be working alone. They will have nurses working with them. They may have physical therapists, a laboratory technician, a pathologist. They may have to interact with other specialties. They may have to interact with other people in the ward. So the collaborative learning is more important because then you can't teach them all these skills, EPAs, and then throw them into a team and say, okay, now work with this team. They need to be able to learn to work with this team in their medical school so they can be trusted. They can be, and they have entrustable professional activities they can do. So the collaborative training with nursing, pharmacy, allied health professionals, leadership training, because many a time physician as a resident is leading the team when they're working with the nurses and all of that. So they need to know how to work with the team, how to communicate effectively, how to do interprofessional or interpersonal issue resolution, and how to keep the patient care as the center of the teamwork instead of infighting of the team. And then during all of this, you also need to make sure that they learn how to take care of themselves, how not to do burnout. The one of the single biggest issue with a poor performance of the resident is that they've stopped caring. They are so burnt out. They have so given up on their kind of become learned helplessness that, oh, I'm not going to be able to do any of this. And then they don't care. They don't care if the patient is suffering, patient is getting worse. And you think, oh, it's a problem with their learning. But it's actually not. It may be the problem of implementation. They may know what to do and they just don't care, or they have so much burnout. So learning how to be resilient against all these hard odds, and to be able to get rid of the burnout or minimize the burnout is becoming an important topic, not only during residency but also in medical school education. So I hope this was a good overview of what are the contemporary trends in medical education, what is changing about how we're thinking about training our medical students. You can reach out to me on my email. You can watch some of what I do on YouTube at my channel, search by my name, and you can also connect with me on LinkedIn. Thank you so much for your time.